Shall I start? So I think it's a very important presentation. So what we are trying to do will first in this, because to avoid the length, shortening the length of presentation, we will first discuss the differential diagnosis per se, and then maybe we can plan another presentation on the interview screen experience and how to approach it. Otherwise, it can be too comprehensive for this capsule. So with this, we start. Good morning, everyone. My topic for today's presentation is how to arrive at a differential diagnosis in personality disorders. And my moderator is Dr. Shobhit sir. Now, the Diagnostic and Statistical Manual of Mental Disorders, it defines a general personality disorder as an enduring pattern of behavior and inner experiences that deviates significantly from the individual's cultural standards. It is rigidly pervasive. It has an onset in adolescence or early adulthood. It is stable through time. It leads to unhappiness and impairment, and it manifests in at least two of the following four areas. That is cognition, effectivity, interpersonal function, or impulse control. Now, this is the diagnostic criteria as it is given in DSM-5. Along with this, we should remember that the enduring pattern should not be better explained as a manifestation or consequence of another mental disorder, and it should not be attributable to the physiological effects of a substance or any other medical condition. Now, the types of personality disorders as it is given in DSM-5 is cluster A, cluster B, and cluster C. Cluster C, it includes three personality disorders with odd and aloof features. That is your paranoid, schizoid, and schizotypal. Cluster B will include four personality disorders with dramatic, impulsive, and erratic features. That is your borderline, antisocial, narcissistic, and histrionic. While cluster C, it includes three personality disorders which share anxious and fearful features. That is avoidant, dependent, and obsessive compulsive. Now, the categories that we will be following in this presentation are anxiety-prone disorders, poorly empathic disorders, and psychotic-prone disorders. Now, anxiety-prone disorders, they include obsessive-compulsive personality disorder, dependent personality disorder, and avoidant personality disorders. The common feature in all three of them is an existence which is riddled with tension and anxiety, and they differ in how this anxiety will manifest itself and how it will be controlled. First, we will talk about obsessive-compulsive personality disorder. Now, this person, he will be preoccupied with details, rules, lists, order, organization, or schedules to the extent that the major point of the activity will be lost. He will show perfectionism to the point that it will interfere with the task completion, and he will be excessively devoted to his work and productivity to the exclusion of leisure activities and friendships. He will be inflexible about matters of morality, ethics, or values. He will also be unable to discard worn out or worthless objects, even when they have no sentimental value. He will not be able to delegate tasks or work to others unless they will do exactly the way he or she does things. He will also adopt a miserly spending style towards both self and others, and he will be very rigid and stubborn. If four or more of the following are fulfilled, we can say that the patient has an obsessive-compulsive personality disorder. Now, the main differential diagnosis of this will be obsessive-compulsive disorder. Now, OCD, it is a chronic lifelong disorder, which is characterized by obsessions and compulsions. It will usually start in childhood and adolescence, and it will usually run an unremitting course. But unlike the obsessive-compulsive personality disorder, OCD will cause serious social and occupational impairment across multiple domains. And a patient of OCPD, he will usually not have morally repugnant urges also. And the clinical factor that best
we can use to differentiate between the two is that a patient of OCD will have greater mental discomfort, more anxiety will be present as compared to the patient with obsessive compulsive personality disorder. The second personality disorder that we are discussing is dependent personality disorder. Now, this patient, he will have difficulty in making everyday decisions without an excessive amount of advice and reassurance from others. He will usually need some other person to assume responsibility for the major areas. He will also not be able to disagree with others because he will fear that then they will leave him. He will have difficulty in initiating projects or doing things on his or her own, and he will go to excessive lengths to obtain support from others, even if those things make him uncomfortable. And he will also feel helpless when he will be alone because he will feel as if he or she is not able to take care of himself or herself. And he will also urgently seek another relationship when a close relationship will end, and is unrealistically preoccupied with fears of being left to take care of himself or herself. If any five or more of the following are present, we can diagnose the patient with dependent personality disorder. Now, dependence will also be a prominent factor in patients with histrionic and borderline personality disorder. But a patient with dependent personality disorder usually have one long-term relationship with another person, and he or she will also not be overtly manipulative, as is found in histrionic and borderline personality. And dependence can also occur in patients with agoraphobia, but a patient of agoraphobia will have a high level of overt anxiety or even panic as compared to a patient with dependent personality. Next is avoidant personality disorder. Now, this patient, he or she will avoid occupational activities which will involve significant interpersonal contact because he or she is going to fear that he is going to be criticized, disapproved, or rejected, and will not be involved with people unless he or she is certain that he is liked by them. So he or she will usually not uh, get into any intimate relationship, and his mind will be preoccupied with being criticized or rejected in social situations. And in new interpersonal situations, he will feel very inadequate. So he will be inhibited in such situations. And he will feel himself that he is socially inept, personally unappealing, or inferior to others, and will be reluctant to take part or to take personal risks or engage in any new activities because he or she will feel that he might get embarrassed in them. So to differentiate this patient with a patient of schizoid personality disorder, we should remember that a patient with avoidant personality disorder desires social interaction, but he is unable to do so. And he or she will also not be as demanding, irritable, or unpredictable as patients with borderline or histrionic personality. And they will have a greater fear of being abandoned. With patients with dependent personality disorder, they have a greater fear of being abandoned or unloved than those with avoidant personality disorder. But usually in the clinical settings, it is difficult to distinguish between the two. Next, we will talk about poorly empathetic disorders. These include schizoid personality, antisocial personality, histrionic personality, and narcissistic personality. They have a peculiar inability to empathize in the same sense. In patients of antisocial, histrionic, and narcissistic personality, we may find a personal history of people who have feel betrayed or manipulated, while in schizoid personality, there may be a true lack of interest in human contact. First is schizoid personality disorder. Now, this patient, he neither desires nor enjoys close relationships. He usually likes to be alone. He also does all the activities alone. And he has little, if any, interest in having sexual experiences with another person. He takes little pleasure in activities. He will not have any close friends or confidants other than first degree relatives. He will be indifferent to the praise or criticism of others and will be emotionally cold or detached. Now, a patient of schizoid personality disorder, he or she can be distinguished with patients of schizophrenia, delusional disorder, or any affective disorder with psychotic features, because based on periods with positive psychotic symptoms, which will be found in patients of schizophrenia or delusional disorder. And a patient of paranoid personality disorder may also share some traits with schizoid personality disorder, but a patient of paranoid personality disorder will be more social. There will be history of aggressive verbal behavior and a greater tendency to project their feelings onto others. And a patient of schizotypal personality disorder, we can say that he or she will be more similar to a patient with schizophrenia because there will be oddities in perception, thought, behavior, and and a patient with avoidant personality disorder, he or she is also isolated, but he or she will wish to participate in activities. And and a patient of schizoid personality disorder will be distinguished from autistic disorder or Asperger's syndrome by more severely impaired social interactions and stereotypical behaviors and interests than in those two disorders. Next is antisocial personality disorder. This patient will have a failure to conform to social norms with respect to lawful behaviors. There will be deceitfulness, repeated lying, impulsivity will be present, irritability, aggressiveness will be present. There will be reckless disregard for safety of self or others, consistent irresponsibility, and lack of remorse will also be present in this patient. Now, this individual should be at least 18 years of age with evidence of conduct disorder with onset before age of 15 years, and this behavior should not occur exclusively during the course of schizophrenia or bipolar disorder. Now, differential diagnosis, we need to distinguish this patient, this patient from a person who does illegal behavior. Now, now it can be distinguished from a patient displaying illegal behavior, and that in antisocial personality disorder will involve many areas of a person's life. And when this illegal behavior is only for gain and it's not because of persistent personality trait, it will be classified as criminal behavior and not associated with a personality disorder. Now, many of these patients will have a neurological or mental disorder that would have been either overlooked or undiagnosed, and many of them will also be abusing any substance. Now, when both substance abuse and antisocial behavior, it begins in childhood and it continues into adult life, both disorders should be diagnosed. But if this behavior is secondary to premorbid alcohol abuse or any other substance abuse, now diagnosis of antisocial personality disorder is not required. And we should also not make a diagnosis of this disorder if intellectual disability, schizophrenia, or mania is present in this patient. Next is histrionic personality disorder. Now, this patient he or she will be uncomfortable in those situations where he or she is not the center of attention. Interaction with others will be often characterized by inappropriately sexually seductive or provocative behavior. There will be rapidly shifting and shallow expression of emotions. Consistently, he or she will use physical appearance to draw attention to self. There will be a style of speech which will be excessively impressionistic, lacking in detail. Self-dramatization will be present and exaggerated expression of emotion will be present. He or she will be suggestible and will consider relationships to be more intimate than they actually are. Now, this patient, now distinguishing between a patient of histrionic personality or borderline personality is difficult. But in borderline personality, usually suicide attempts or identity diffusion and brief psychotic episodes are more likely. Somatization disorder may also occur with histrionic personality disorder, and and a patient with brief psychotic disorder or dissociative disorders may also require a coexisting diagnosis of histrionic personality. Next is narcissistic personality disorder. Now, this patient, he will have a grandiose sense of self-importance, will be preoccupied with fantasies of unlimited success, power, or brilliance. They will believe that they are special and unique, and they should only associate with other special or high status people. They require excessive admiration. They will have a sense of entitlement, will be interpersonally exploitative, lack empathy, will be envious of others, and will show arrogant, haughty behavior or attitudes towards others. Now, we should now differential diagnosis of narcissistic personality. We can have borderline, histrionic, and antisocial personality. Now, a patient of narcissistic personality disorder, they they usually have less anxiety than those with borderline personality. Their lives are less chaotic and they are less likely to attempt suicide. And and a patient with antisocial personality disorder will have a history of impulsive behavior, and often there will be comorbid substance abuse with them. And a patient of histrionic personality will show features of exhibitionism and interpersonal manipulativeness. Now, last are the psychotic prone disorders. Now, now the defensive structure in these patients is reminiscent of the defenses which are used by children. These include magical thinking, preoccupation with internal fantasy worlds, and tendencies to act impulsively or out of rage. And when pressured, they may also experience micropsychotic episode, because these defenses, they sweep them into a false reality. Now, the first disorder in this is borderline personality disorder. Now, this patient, he or she will make frantic efforts to avoid real or imagined abandonment. There will be a pattern of unstable and intense interpersonal relationships. Identity disturbances will be present. Impulsivity will be present in at least two areas, which are potentially self-damaging. Recurrent suicidal behavior or self-mutilating behavior is present. Affective instability is present, chronic feelings of emptiness, and inappropriate, intense anger or difficulty controlling anger, and transient stress-related paranoid ideation with severe dissociative symptoms. Now, borderline personality disorder, it may be mistaken for schizophrenia. However, instead of long-term psychotic episodes, these patients will experience micropsychotic phenomena of short duration, which lasts hours or at most a few days. Along with this, auditory hallucinations will also be present without loss of insight, while we know that in patients of schizophrenia, loss of insight is also present. Along with this, there will be paranoid trends and depersonalization states. Now, this table, it shows the it shows the differences in symptoms which we can help to distinguish between borderline personality and other diagnoses. Now, depression, if it is found, we can differentiate it from major depressive episode, because in major depressive episode, the lowered mood will be extended and continuous. While in borderline personality, it is usually short-lived or subclinical. Now, we will discuss later how to differentiate between borderline personality and bipolar disorder. And we have already discussed how to differentiate between borderline personality and schizophrenia. The borderline personality disorder and bipolar disorder. Now, the main features which distinguish between bipolar disorder and borderline personality disorder is that in bipolar disorder, usually the history which will be present, the distant or rejecting parents will be unlikely. Any history of childhood abuse or sexual abuse will usually not be present. And while in borderline personality disorder, the such history we might get. Second is that the psychotic features which are present in bipolar 2 disorder, the in they are usually they are usually for a longer period as compared to the micropsychotic phenomena in borderline personality disorder. And the emotional regulation which is done in bipolar 2 disorders, maladaptive strategies, they're less severe as compared to patients with borderline personality disorder. And and usually a patient of bipolar disorder will have stable interpersonal relationships, and there will be less avoidance due to rejection as it is found in borderline personality disorder. And self-identity, it is usually impacted during the mood episodes in bipolar, but when the patient he is not symptomatic, where it's euthymic, it is usually stable. And the mood episodes, they are likely to respond to mood stabilizers and atypical antipsychotic drugs, while in borderline personality, there is poor response to mood stabilizers and there is non-specific response to medications. Next is schizotypal personality disorder. Now, this patient, he will have ideas of reference, odd beliefs, magical thinking is present, unusual perceptual experiences are present, odd thinking or speech is present. There will be an inappropriate constricted effect, and the behavior will be odd, eccentric, peculiar. There will be lack of close friends and confidence, and excessive social anxiety. Now, again, we have already discussed how to differentiate between schizotypal personality disorder and schizoid personality disorder. Now, these patients, they can be distinguished from those with schizophrenia by absence of psychosis. And if psychotic symptoms do appear in these patients, they are brief and fragmentary. And we can differentiate them from paranoid personality disorder by suspiciousness, but they lack the odd behavior of patients which with schizotypal personality disorder. Next is paranoid personality disorder. Now, this patient will suspect without sufficient basis that others are exploiting, harming, deceiving him or her, will be preoccupied with unjustified doubts about the loyalty, trustworthiness of others. There will be reluctance to confide in others. And he will also read hidden, demeaning, threatening meanings into benign remarks or events, and has recurrent suspicions without justification regarding fidelity of spouse or sexual partner. Again, they can be differentiated from delusional disorder. There are no fixed delusions present in this patient. And from paranoid schizophrenia, they have no hallucinations or formal thought disorder. And patients with paranoia, they also lack the long history of antisocial behavior of persons with antisocial character. And patients with schizoid personality disorder, they are withdrawn and aloof, and they do not have paranoid ideation. Now, two personalities can also be mentioned in this presentation. First is passive aggressive personality. They are characterized by covert obstructionism, procrastination, stubbornness, inefficiency. They should be differentiated from histrionic and borderline personality disorder. They are usually less flamboyant, dramatic, effective, and they're more openly aggressive than those with histrionic and borderline personality. Second is sadistic personality disorder. Now, these beginning in early adulthood, these patients, they have a pervasive pattern of cruel, demeaning, aggressive behavior, usually directed to others. Physical cruelty or violence is used to inflict pain on others, not to achieve any other goal. And they also like to humiliate or demean persons in front of others, and have usually treated or disciplined persons uncommonly harshly, especially children. And they're also fascinated by violence, weapons, injury, or torture. Now, we will also make a mention about alternative DSM-5 model for personality disorder. Now, in this personality disorders, they are characterized by impairments in personality functioning and pathological personality traits. The specific personality disorder diagnosis, which is derived from this model, include antisocial, avoidant, borderline, narcissistic, obsessive compulsive, and schizotypal personality disorder. And this also includes a diagnosis of personality disorder or trait specified, which can be made when a personality disorder is considered to be present, but criteria is not met. Now, this is the general criteria for personality disorder: that a moderate or greater impairment in personality or functioning is present, one or more pathological personality traits. Impairments in personality functioning in individuals' personality traits, they are relatively inflexible, they're pervasive across a broad range of personal and social impairments. And the impairments, they are relatively stable across time, and the onsets can be traced back to least adolescence or early adulthood, and they cannot be explained by another mental disorder, not attributable to the physiological effects of a substance or another medical conditions. And the impairments, they are not better understood as normal for individuals' development stage or socio-cultural environment. Now, the criteria A, the elements of personality functioning includes disorders in self and interpersonal relationships. Self is like identity or self-direction, and interpersonal is empathy or intimacy. And pathological personality traits, they're characterized into 5 domains: negative affectivity, detachment, antagonism, disinhibition, and psychotism. These are my references. Thank you.
I think with this, we open the floor to comments and clarifications. Doubts?
In a patient of obsessive compulsive disorder, obsessions and compulsions are present. Obsessions are your unwanted intrusive thoughts. And usually, in a patient of OCD, more severe functional impairment is present as compared to a patient with a personality disorder of the same. And usually in OCD, also some obsessions are present which are not, which are ego dystonic to the patient. And this is usually not found in a patient of obsessive compulsive personality disorder. I don't think so, because I think that they understand that what they are doing, but I don't think that they feel that.
Personality disorder. For the basic definition, personality disorder should be met in every case. ये standard definition है, ये should be uh, should be met if this is fulfilling it, and with the criteria of UCPD. Inside is a different construct altogether. They will